Good day, good morning, good afternoon, good evening, depending on the time that you're joining us. Welcome you to today's webinar. The theme for the webinar is sterile success, infection control in the operating room. And this webinar is organized by the GICS, the Nursing Working Group of GICS. GICS stands for the Global Initiative for Children's Surgery. So we want to say welcome, welcome. We are happy to have you here. My name is Titlope Idris. I'm a pediatric nurse with 13 years of experience, and it's a privilege for me to be moderating this session. So we would like to say once again, we have different professionals that are joining from different regions, different groups, different country, all over the world. I want to say thank you for making out time out of your busy schedule to be part of this. It reflects the fact that we are all committed to having a safety, to ensure safety and excellence in the surgical unit. Thank you so much for joining us. So without wasting too much of our time, I would like to move on to the welcome address, which is going to be taken by Professor Vinitha. Professor Vinitha she's the GICS Nursing Working Group lead. She's the indefatigable chairman of the Nursing Working Group of GICS. And then she's also the former Dean College of Nursing at Vellore, India. So Professor Vinitha, you're welcome to take the welcome address, ma'am.
Thank you, Titi, for that opportunity. I'm here. I know Professor Ravindran's the information is on the slide. On behalf of Professor Ravindran, I'm here to say a few words of welcome as Professor is away in a community hospital doing surgery. So I'm just taking this opportunity to welcome each one of you on behalf of GICS, that is Global Initiative for Children's Surgery. This is a webinar organized by the Nursing Working Group.
No problem. You change this one. It's nothing.
Very strong group of nurses who work together on different topics.
You have to give him again.
Hey,
you know
I'll
why?
give him now.
Professor Hyatt? Yeah, okay, thank you. So on behalf of the chair of Global Initiative for Children's Surgery, Professor Vinitha Ravindran, I invite each one of you for this webinar. I would be later saying a few words about what we do and what our focus is on in the nursing working group if there is time. But at this time, I just take this opportunity to invite each one of you for this webinar. And I hope that this hour will be a very useful one for you. And as you listen to the speakers and as you listen to the activities of the nursing group, we invite your ideas. And if you have any ideas, any suggestions, any comments that you have related to the talk or related to just your interest in nursing working group of GICS, please put it in the chat box so that we can address those questions and comments and suggestion, and we can take this up further. So I hand the session back to Titi and welcome each one of you. Special welcome to each one of the speakers, especially Professor Hyatt, Ms. Kaye, and Mr. John Meshack here. So welcome each one of you. Over to you, Titi.
Thank you so much, Professor Vinitha. Thank you.
Thank you so much.
Yeah, so we all know that infection control in the operating room is more than just a protocol. It is the foundation for a safe surgery. So every one of us, different professionals that are here, nurses, I'm sure that there are some other professionals that are here. We all have that role to play to maintain the sterility, to maintain that atmosphere in the surgical units to prevent against infection. So today's section is going to be insightful. It's going to be interactive enough. We'll encourage you to pay attention to the speakers. We want you to note your questions because there's going to be a question and answer session at the end of the session, at the end of the web presentation. There's going to be a question and answer. So I want you to put down your question. There's going to be time for you to also share your thoughts as we continue in the webinar today. So the main objective of our webinar is that we want to reinforce the basic knowledge reinforce the basic knowledge on asepsis in the operating room. We want to identify the ideal attire in the operating room. How should we present ourselves? How should we dress up? How should we kit up ourselves? And current updates. What are the current updates that we see? Or we know we have people that are joining from all over the world. So we want to see what is happening in different places. What are the current updates? And then we are going to be looking at present evidence-based practice in the operating room. What is operational currently in the operating room. So we want to learn, we want to improve on our learning, we want to learn from one another. So I'd like you to sit back as we continue in today's webinar. Like I said earlier, put down your questions. So without wasting too much of our time, I would like to go into introducing my guest. I have the honor to introduce the guest speakers of today. Our first guest speaker is Mr. Meshack John. Meshack John is a registered nurse. He works in Tanzania, Muhimbili National Hospital. So he's a registered nurse with extensive expertise in surgical safety, and he will be opening today's section by speaking to us on aseptic techniques in the operating room. Over to you, Meshack. And you have 15 minutes, please. Thank you.
Okay, yeah, so I start. Okay. Do I share my slide or somebody can share on behalf?
Hey, is Kaye able to share, please?
Yeah. Hello, can I share my slide?
Kaye is sharing.
Oh, Kaye, okay. Kaye is sharing on behalf. Thank you so much. As Titi has introduced me to the platform of the Global Initiative for Children's Surgery, my name is Meshack John. I'm a registered nurse. I'm also a perioperative nurse working in a pediatric operating room at Muhimbili National Hospital. As my topic was to present you on aseptic techniques in the operating room. Working in operating room needs a very sensitive environment because we have to make sure that the patient, as the patient comes for surgery, we have to make sure the patient don't get surgical site infection. As getting this infection can lead to a lot of complications, like long hospital stay, burden to the patient because the patient may need to pay a lot of bills by staying long time in the hospital. With the other lot of psychological issues, so it's very critical to make sure that at least we maintain the sterility and the aseptic technique in the operating room. So this topic has 4 objectives. So at least first was to discuss the principle of aseptic techniques and demonstrate the surgical hand scrubbing, gowning, and the graving procedure. So also environmental control, creating and maintaining sterile field. Also, the last objective was the importance of aseptic techniques. So aseptic technique generally is an essential practice in the operating room that prevent contamination and minimize the risk of infection during procedure. So these techniques are very crucial for the patient safety and the good and successful surgical outcome. So the operating room is a place where place of full of critical factors due to the type of surgery, due to the be performed, the people present, and the procedure to be put in place. That is why it's very important to follow for some unavoidable rules to know how to move around in the operating room and how to act correctly in the operating room. So these techniques is very important. As a patient or any person getting injury of the skin or needing any surgical intervention, so as we deal with any invasive procedure to the patient, so all aseptic techniques should be adhered to make sure that the patient is safe during surgical procedure. So the key principle of aseptic technique is starting in sterilization of instrument. So the process of sterilization of instrument and all material needed to be used in an operating room should be sterilized to eliminate all microorganisms. So there's a lot of there's this common method which is including autoclaving, ethylene oxide, gas, and the chemical sterilization, especially in most of our hospital. Mostly we use autoclaving, but maybe in some procedure like laparoscopic instrument, mostly we use chemical sterilization in our hospital because mostly of our facilities don't have a sterilizer machine for laparoscopic instrument. So we mostly use chemical sterilization to sterilize the laparoscopic instrument. But for other instruments, mostly we use autoclaving machine. So this is very important in maintaining the sterile instrument for the sterile procedure. Also, we have other principle of surgical hand scrubbing. So surgical hand scrubbing, some use water and soap, but now mostly recommended is alcohol-based and antiseptic. But actually in our hospital, we usually use soap and water, of which maybe it's cheaper, but now mostly recommended one is using alcohol-based antiseptic. Is very good for the sterility and the disinfection of microorganisms during scrubbing. So all surgical staff who will be performing surgery, like surgeons and the nurse, should have to scrub before gowning and attending the operating procedure. So thorough hand washing and the scrubbing is needed. As early in the morning, as we start the procedure in the morning, we need to start with the social hand washing, then followed by surgical scrubbing. And this procedure for the first case should take at least 3 to 5 minutes if we are scrubbing using soap and water. But for those who are using alcohol-based antiseptic, at least 90 seconds, which is 1 minute and 30 seconds, is enough to scrub using alcohol-based. So also things to consider before scrubbing. We need to remove our jewelries, watches, ring. This must be removed before starting scrubbing. Also, we need to do pre-washing, especially if we are coming from our home. So we need to do pre-washing is like a social hand washing. And then we also have to look for nails. So this is the second part. So as I said, so you sometimes use the blush or sponge and aseptic solution, although some other studies discourage using of blushes because sometimes blushes can cause, it can make the skin be at risk of getting infection. Also, so we have to clean the fingers, hand, forearm, systematic using time or stroke-based method. So after that, we rinse thoroughly, keeping hands elevated above the elbow according to keeping the hand elevated throughout the procedure of scrubbing, and also dry hand and the forearm with sterile towel. Then after drying the hand, we can now put it on surgical gown. But also if we are using surgical hand scrubbing of alcohol-based hand lab, so apply alcohol-based hand lab according to the manufacturer's instruction, ensuring complete coverage according to the Well-Share Acute Hospital Trust. So after that, it follows the procedure of putting gowns. So we make sure a person who is scrubbing, also he has put on the cap, put on face mask, put on theater shoes. So we assume that now as the person have already scrubbed, now he put on a surgical gown, which is sterile, and also after that will be followed by gloves. So this creates a barrier against the contamination. So proper donning and the doffing of personal protective equipment reduce the risk of spreading pathogen during surgery. Also, another thing which is very important is after scrubbing and gowning, the other thing which is very important is to create and maintain a sterile field. So you can see, like I put a picture here. So now you can see an anesthetist there. Now there is a surgical person who is standing on the sterile field. So it is very important to make sure only a sterile item should encounter this field, and it must be maintained through the procedure. So only a sterile item should contact or encounter this sterile field of the table, which has been covered with the dressing, and also the trolley, which has sterile, and the mayo table, which has a sterile instrument. So only a sterile instrument should be counter this area. So even the movement should be limited. So a person who is not sterile should not contact this area. At least it should be at least 1 meter away from the sterile field, 1 meter away. So, and sometimes it happens, mostly we are working in a teaching hospital. So sometimes we might have a student who are maybe resident and the medical student. They need to watch very close to see what is going on, but we have to limit at least 1 meter away. Also, sometimes it happens maybe a surgeon is doing surgery, but he or she needs a consultation from other surgeon who is not sterile. So maybe a surgeon needs to come closer to the operating table, which is sterile. So we have to limit. As a nurse is the one who controls sterility in the operating room. So a nurse should make sure the sterility is maintained by minimizing this contamination. So at least we can tolerate if maybe a surgeon is asking an opinion from a non-sterile surgeon who want to come close and to watch and give their opinions, at least not more than 30 centimeter closer to the sterile field. But normally it's only 1 meter allowed. Only 1 meter allowed to the someone who is not sterile to be closer, the distance 1 meter away from the sterile field. So another thing is environmental control. So the operating room should be clean and well maintained with the controlled airflow and the temperature. So also regular cleaning and the disinfection of surface and the equipment are vital. So even before we start the procedure, so the health assistant should assist making the cleanliness of the operating room. But after each procedure, we have to carbolize the mayo table, trolley, sometimes we don't use spirit or chlorine, at least to make sure we disinfect all the table and the trolley, all equipment used to put sterile instrument. So we have to also to limit traffic control. Movement of the people of personnel in the operating room should be reduced. So at least making sure that only people who have special task in operating room are those who should get in the operating room. So there's no specific number who should get in the operating room, but we have to make sure at least very few personnel can get in operating room. So sometimes there's a challenge for the teaching hospital. You may find we have resident maybe of pediatric surgery, maybe we have other medical student, intern nurse, intern doctor. but we have to limit, at least, because as the number of personnel increase in the operating room, so the chance of contamination also increase. So sometimes if we have other operating rooms, you may advise some of the students and the other personnel to go in the other operating room so that they can watch in further procedure if the number of personnel inside the operating room is too much. So we need to limit the number of personnel in the operating room so as to reduce the risk of contamination. So this is very important. The other thing is the proper handling of sterile item. So in order to avoid the contamination of sterile item during transfer or use from transfer and use from non-sterile person. Maybe I'm a scrub nurse. I want to get a suture from a circulating nurse. So sterile technique should be considered. Also, the way of handling instrument from scrub nurse to a surgeon, and from a surgeon to a nurse should be maintained, because this also increase the sterility and also safety for the nurse and the surgeon. For some of the instrument we handle to surgeons are sharps like needle and knife. So we need to use a sterile technique to handle those instruments, and also to make it easier for the surgeon to perform surgical procedure. So we need to adhere to proper handling of surgical sterile instrument from surgical nurse to surgeon. So the last point is this importance of aseptic techniques. So why aseptic techniques? So the main goal of this aseptic technique is to prevent infection. So this reduces the risk of surgical infection, which can lead to complication of prolonged hospital stay and increased healthcare cost. If the patient encounter with a surgical site infection, maybe with the procedure like maybe inguinal hernia repair, maybe the patient should stay in the ward maybe for 2 days. So if the patient gets infection, this can lead to the patient to stay even 2 weeks in the hospital. So it brings a lot of psychological effect, also to increase the burden to the patient and the guardian who take care of their children, because they need to pay more bills to the hospital. But sometimes surgical site infection can lead to death. It makes a lot of morbidity complications. So it's very important to maintain this aseptic technique because of preventing infection. Also for patient safety. So enhance overall patient outcome by ensuring a sterile environment during surgery. Also, aseptic technique is also a standardization of practice, because this aseptic technique, it's a global standard. What we practice maybe here in Tanzania, it should be the same in which is done in maybe in the Philippines, should be the same in Egypt, should be the same in other countries, because it should have a standard. By establishing a consistency protocol helps all team members to understand their roles in maintaining aseptic technique. So in conclusion, aseptic technical foundation to the practice of surgery. By following these principles diligently, surgical team can significantly reduce the risk of infection and ensure the safer surgical experiences for patients. Continuous education and adherence to this practice are crucial for all operating room personnel. So this is the end of my presentation, and there's also some references of books. Thank you so much for GICS team and the TT. Thank you. And this marks the end of my presentation.
Thank you so much, John. Thank you for that beautiful, insightful presentation. Thank you for reminding us that there are so many things that you have pointed out that we are supposed to note. And I'm sure that the audience are noting I believe that most of the people that are joining today are nurses. They are nurses working in the OR. Some of us are working in the OR, and we are familiar with some of the points that John has reminded us of today. There are things that we are doing. I just want to highlight some of the things that he mentioned without wasting too much time. You have talked about the how to minimize infection in the OR and starting with sterilization of our instruments. I know those practices, some of these things that you have mentioned, they are a bit different from the protocols are a bit different from for in various regions and different locations, how we sterilize our equipment. Some have their equipment all packed, while in some parts of the world, most especially in Africa, most of us have it still. We have to be the ones to we have to do it manually, sort of. They are not sealed, they don't come sealed, while in some part of the world it is sealed. So we have different practices that are obtainable in different parts of the world. But the most important thing is to ensure that whatever practices that we are using, the sterility of our equipment is maintained. Thank you so much. You talked about the principles. You went over the principles of hand washing, how to removing our jewelries, how to don and doff the surgical, the protective wears, all those things. They are very important, and they are things that we should pay attention to. In the comment section, our audience, I would like us to drop what is that one aseptic technique that you think is easily overlooked, that you think that it's easily overlooked in the OR that you have observed from your own experience. I would like you to drop that in the comment section. I'll be expecting your response while I introduce our second speaker for today. While I go ahead to introduce our second speaker for today, I'd like you to drop. My question is that what is that procedure, that aseptic procedure technique that you think that is easily overlooked from your experience in the OR? What is that procedure that you think is easily overlooked? I would like to see responses from us, please. So we are going to the next topic that we are going to be talking about today. Our presenter is Kaye Avellano. She's also a registered nurse. She's a member board of trustee, the corporate secretary of World Surgical Foundation in the Philippines. She's also the advisory council perioperative registered nurse, a member of the advisory council Perioperative Registered Nurse Association of Philippines. So she's going to be speaking with us on the topic the ideal operating room attire. You're welcome, Kaye.
Hello, everyone. So let me just share my screen. Are you able to see it now? Are you able to see my slides?
Yes, but
Please.
it's not in
Yes, please.
mode.
What?
I don't see it in slideshow mode, Kaye. If you can, yes, now it's good.
Now it's okay.
Yes.
It's okay now.
Okay, thank you so much. So, good evening, good afternoon, and maybe good morning from other participants. So, indulge me in the next 15 minutes as we all find out if there is really an ideal attire for the operating team. This short lecture will hopefully help us identify strategies on how to ensure compliance to infection control standards and encourage our stakeholders in the operating room to adhere to standards of infection control and the use of the appropriate OR attire. The idea of the operating room attire always coincides with the thoughts of operating room zoning. The zoning will enable us to identify the traffic flow inside the OR complex, clothing allowed to wear in every zone, and the level of protection necessary in each zone. OR zoning is divided into unrestricted, semi-restricted, restricted, and just recently I came across an article where they emphasized the fourth zone or the dirty zone. The unrestricted area is often regarded as the entrance to the operating room complex, wherein personnel are allowed to wear street clothes and traffic may not be limited as anyone may come and go freely in this area. This area includes our admitting or reception area, administrative offices, which may include the offices of your chief of clinics or the chief nursing officer or operating room managers. In some facilities, this is where the locker rooms or changing areas as well as lounges or pantries are located. The next zone in the OR is the semi-restricted area where operating room attire is required. Common areas in this zone will include the nurse's station, where scheduling is done, holding bays or induction rooms, the post-anesthesia care unit, the central sterile supply, and some may include instrument processing areas. The corridors or hallways to the restricted areas are often separated by a red line. Most facilities will have separation using doors, signages to remind the team that the next zone will be the restricted area, or what is commonly familiar to us as the sterile area, in which most of the time, the only people allowed entry will be the members of the surgical team. In this area, a complete surgical attire is required and traffic is limited and monitored. This shall include our operating suites, the scrub areas, the gowning and gloving areas, and the sterile instrument and supply rooms are located. The last zone shall be the dirty zone or our disposal area, wherein personnel are required to don protective personal equipment while handling contaminated items used inside the operating suites. It can also be the areas where trash bins are cleaned, hampers are emptied and disinfected, and in some facilities, this could be where doffing area is located. Is there really an ideal operating room attire? Yes, of course. The surgical attire in the OR are expected to promote safety and hygiene as well as freedom of movement and comfort to the one wearing them. It should comply with the standards so that it prevents the spread of pathogenic microorganisms that might increase risk for surgical site infection. And lastly, our OR attire should exhibit professionalism by ensuring that we adhere to the protocols and standards in the operating room. The basic and common surgical attire would include the following: the scrub suits, the hair cover or our caps, the surgical mask, and of course, our operating room shoes or booties or our clogs. Scrub suits comes in normal V-neck top and drawstrings or elastic waistband pants. Top and drawstrings are tucked in to prevent contamination. A low lint material will minimize shredding of clothes material in any part of the sterile field. Impermeable material will minimize fluid to pass through the fabric. And scrub suits should be easily laundered and can withstand high temperatures, use of bleach, and washing solutions used for disinfections. The head cover, or what is commonly regarded to as bouffant cap, may come in a bouffant or skull cap form. Hoods can be worn to secure facial hairs like beards. Material can be fabric or non-woven like our disposables. So, surgical masks, which also can be fabric or non-woven, may come in tie-up or ear loop form. Another option is to wear them with a built-in facial shield. The use of surgical masks will prevent the spread of respiratory droplets or secretions from both healthcare workers to the patient or vice versa. There are a number of masks available, and use may be dependent on the type of case in the OR. Regular face mask, surgical mask, KN95 or N95 mask, which requires feed tests, has proven to filter out airborne particles. Footwear or shoe covers should be made of non-skid material that is properly fitted to provide stability and sole grip to prevent trips or slips. Closed-toed or one that can cover the entire foot is recommended for added protection. No holes or perforations, so much so that it's resistant for splashes of blood or fluids, or secured in cases of instrument falls, especially those with sharp edges. Disposable shoe covers are to be thrown after use, while reusable shoes should be washed regularly or when soiled. It is recommended that there should be a dedicated shoes or OR clogs that is only worn inside the operating room to prevent contamination and spreading microorganisms from outside. While it sometimes gets extremely cold in the OR, some personnel may opt to wear scrub jackets, but it may be best to remind them to wear a new set every day or replace when soiled. Water repellent apron may be worn in some cases in orthopedics or urology cases, like our cystoscopies or our arthroscopies. It is recommended that these undergo proper disinfection every after use, and that best that it's used when fully dry. Boots in some cases of water spills, like as I mentioned, arthroscopies and cystoscopies, are recommended to be washed and disinfected every after use. Goggles or face shields may be optional in some cases, but wearing reusable shall require proper disinfection or disposal. Lead or radiation protection gowns should undergo disinfection every after use. We may encounter a lot of issues and concerns in the use of our surgical attire in the OR. Is anyone guilty or not guilty of this? Let's find out. So maybe our participants will be able to key in your answers if you are guilty or not guilty. So let's start. How many of you are guilty of wearing your scrub suits outside the OR or just putting on a gown as cover up? The use of undershirts that may be visible and may contaminate any sterile item or field are discouraged in the operating room. Or others may have used a loosely fitting scrubs or too tight that it affects comfort and freedom of movement in the OR. What about not wearing their mask properly? Nose clips are not snugly fit or may be worn with their noses not covered entirely. Strings are loose so much so that it hangs freely on your neck and might contaminate or compromise sterility. Excessive touching of our mask or pulling it down when you talk and letting it freely hang on your neck or your ears. And it is recommended that masks are replaced every after surgery. Guilty or not guilty? Who among you here are guilty of wearing caps that does not really provide full cover, so much so that hairs are exposed or going off the cap already? Caps are to be changed daily or when wet or visibly soiled. Reusable head covers are to be laundered accordingly. With regards to OR shoes or booties, we may all be guilty of wearing clogs with holes or perforations or footwear that are not fitted or stable because it's the only one available in the changing room. Or who still wear rubber slippers in the OR? It is good when you have an OR dedicated shoes, but make sure that it's also washed regularly and accordingly. Current trends in the OR attire combines function and fashion so that there's a level of comfort and still adheres to standards in infection control. One example is color coding for days or shifts or roles in the OR to sustain controls and ensure compliance. While we maintain cost efficiency and effectiveness, we also develop strategies that will contribute to quality and safety. So what could be the future of operating room attire? In an article I read recently, we may be looking at integrated smart technology, augmented reality, and even robotics elements. The possibilities are endless. On how this could happen, let's wait and see. Just like any other concerns in the OR, challenges that we encounter in relation to surgical attire can be managed by education and orientation, resource management, and patient advocate. Let us go through these one by one. With regards to education and orientation, this begins with establishing basic knowledge and standards of the organization. This can be done through unit orientations and huddles to remind everyone of the policies in place. Policies needs to be reviewed on a regular basis to ensure that still aligns with the current standards. Random checks or scheduled audits may be done to ensure compliance. If in any instance that you encounter variances, ensure that non-punitive resolutions are in place to address the concerns encountered. Simple reminders, visible signages, and visual communication may be able to provide consistency in practice. Next is resource management, wherein availability of supplies will provide access of healthcare team members and encourage compliance to protocols. If you provide them with the right scrub suits, they have masks, they have cups, shoe covers available, then it is easy for them to comply. It is quite difficult to implement standards when there is scarcity of resources, but we can always find ways to innovate. Stakeholders are recommended to get involved in sourcing out stocks and making sure that items meet the standards. And the most important of all is that we become patients' advocate by doing the right things even when no one is looking or checking in on us. By practicing compassion so that we do things out of genuine care to our patients and putting ourselves in their shoes, we treat other people the way we wanted to be taken care of. You imagine when you are there in the OR, would you like other people to attend to you the way you do with your patients? And as a major takeaway, please allow me to remind us that surgical conscience is the moral obligation to uphold and defend asepsis and safety, no matter the cost or the consequences. May we always keep that in mind. So, ladies and gentlemen, perioperative nurses, thank you very much for your kind attention. Over to you, Titi.
Wow, wow. Thank you so much, Kay. Thank you for that very insightful presentation. I was looking at the comment section while you were speaking about the guilty or not guilty. I was trying to see if we are responding. I can't see any response, but I know that majority of us are guilty of one thing or the other that she has mentioned. Wearing your the OHR outfit outside the OHR, whether not putting on the proper shoe, not putting on your cap appropriately, not loosely fit mask. A number of us are some people are kind of guilty of some of these, but I'm not seeing our comments in the comment section. I'm trying to look out for it. So are we saying that we are not guilty of any of this? We are not guilty of any of these. There is none of it that we are guilty of. Anyway, if we are not guilty of it, that's a good one. Even if we are not guilty, we should have just said not guilty. We are not guilty of it. Thank you so much, Kay. And I love the way you ended when you said our surgical conscience. We should apply surgical conscience. You need to treat people when you are dressing up, whatever it is that you're going to be doing in that surgical unit, in that surgical suit. Don't just do it as if, yes, I don't this person that I'm treating or this person that I'm attending to does not matter. Do it how you would like to be treated, how do you want to be attended to. You should do it with conscience. Thank you so much, Kay. So if we if you have any question, don't forget to put your question in mind. You can write it somewhere so that you don't forget. Keep in mind that our speakers are going to be taking questions before at the end before we end the session. I asked a question earlier, and I'll just read off some of the comments that I saw that were dropped. Some of us answered when I said, what are some of the things that we experience in some of the aseptic techniques that are overlooked, that we overlooked in our own operating room? And some people have answered some of the questions. Somebody said, this is from Niliel. I'm not sure I'm pronouncing the name well. Niliel, pardon me. It says maintaining sterility, especially around the table, is a challenge, especially in the facilities which are teaching hospitals, and they lack a camera to show what is going on. So the place is overcrowded. That is controlling the environment, overcrowding. That is one of the issues that Niniel is talking about, that she experienced in HOHAR. So, okay, this is from Prof. Nabila. Prof. Nabila says, one of the overlooked technique is scrubbing. Yes, I observed multiple times that more focus remains on sterilization of instruments or drapes, but surgical team either scrub incorrectly or scrub for less than required time. Thank you so much. That is something that should be looked into. I'm sure that that is something that we can take away. And I think we can also point it out through education, through pointing it out through our continuous development programs that we do. There are things that we should talk about to remind ourselves. Thank you for that comment. I'd like us to keep our comments coming in as we go on in the session. So we are going to be having our final speaker. I'll be bringing in our final speaker now. And that is in person of Professor Hayat Goma. Professor Hayat is she is also a registered nurse. She is the postgraduate program coordinator at Ahmadu Bello University. She's a seasoned lecturer. She works both in Egypt and in Nigeria, and she's going to be speaking with us on evidence-based nursing practice in operating theater. Join me with a good ovation to welcome on board Professor Hayat. You're welcome, ma'am.
Hello, Titi. Hello, everyone. Good morning, good afternoon for everyone. I'm so happy to be among you today for this webinar. I'm so happy about that. We are the first speaker. They speak about the practice in OR. And now I'm speak about it. What is this practice? What is the evidence base for this practice? Okay, so allow me to share. Yes, it's now. Okay, yes, I can share my screen now. Sorry, yes. Did you see my screen, please?
Yes, we can see the screen.
Yes, yeah, thank you so much. So I'm so happy to be a member in the Nursing Working Group in Global Initiative for Children Surgery. This is just my own the webinar today. It is a sterile success. What is the infection control in the operating room? And I think all of you know that it is very crucial and very important topic about this one. The first speaker updated before they are speak about what is the practice in OR, what is the sterilization, what is the attire, what is the hygiene, and what is the disinfection, and all of this is one. It is not come suddenly like that. It come based on the evidence based. So my topic today, it is just to link between between the theory and the practice. In academician and in the university and in any educational institute, you just make a research to get what is the best result, mainly for the importance of the care of the patient. Okay, the second here I have to do the second one. The objective of this session, I have only about 15 slides, so I will not take much time about this one. I have only two objectives here, just to explain the goal and the importance of the implementation of evidence-based nursing practice in the operating theater, mainly for improved patient safety and surgical outcome. And all of this is what happened when the Kaye and the Meshack, they speak about that. Why we keep information, we keep information, we keep knowledge, we keep updated sterilization technique and something like that. The second objective here is to identify and apply the key evidence-based strategic and the protocol to preoperative nurse should be used during preoperative, interoperative, and post-operative care. All of us, we know that operating room nurses are medical professionals. Sure, they have to be licensed and they have to have full experience in operating room, what is the procedures, what is the instrument, what is the tool, what is the rule, and also they have a specific skill that we will know later for this one. So it is assessed mainly to assess the physician, because the nurse is not allowed to do this operation to assess performing the procedure. The rule of this nurse is required competent. We have to know this competent communication skills and the ability to work in fast-based environment. This is very, very crucial. Fast-based environment, so we are save the patient. I remember one day when we are making exploration, and when the doctor the portal vein, it is unintentionally cut the portal vein, and this is one we find the stomach of the abdomen, it is full of blood. And directly God, this is the clamp and the close this one, and all of us, we say Alhamdulillah, because we saved the patient life at this time. We have specialized the skills for this nurse. It has to be knowledgeable about the sterile technique, and he and the Meshack mentioned, the ability to handle surgical instrument. They have a specific way how to give this instrument and the specific arrangement of the tray, which one is first, which one in the middle, which one is the second. And I think they are speak about that. And also quick decision making under pressure, because when we are open, this is we have in the operating theater, and we are, all of us are stressed. Still we are stopped. Till we would start from, we start the incision till the clothes, and they are everybody just put off his old gown, and we say Alhamdulillah. And also when the patient, they are recovered, and they are recovered, and they say Alhamdulillah, and allow him to leave this operating theater. And also stronger communication. When stronger communication, sometimes you are not able to speak in the operating just by eyes. Just by eyes, we can understand the communication between the physician and the assistant and the scrub nurse and circulating nurse. Now, this is okay. This is the first nurse and the operating. What is skills? What is about evidence-based, and why we are put it evidence-based here? Why we are put evidence-based? We put it evidence-based now because it is the integrating the best current research with the expertise, with the Kaye and with Meshack. They are speak. They are not make it like this one. How to make aseptic technique, how to make hand hygiene, how to make it, what is the percentage, and what is the percentage of the antiseptic solution, for how long I have to put it this one in autoclave. All of this one based on evidence. So we are need this evidence mainly to save the patient life and also to secure the quality of life. So best I have level. The highest level, or the level number one, is systematic review and the meta-analysis. That is the highest level. If you wanted to go at high level and of this information and the data really to apply in practice, you have to make systematic. The second one, randomized control. The third one, control trial without randomization with this quasi-experimental. And the many of this high level, this is the third level. We have quasi-experimental in all our departments, especially in PhD student. PhD student, all of them, they have to make quasi-experimental to ensure the quality of the result they got it. And the many of these patients, they are the student, and they are doing that. They have systematic review before this one. The other for level 4 is case control and the cohort study. First, level 5 is systematic review, qualitative and descriptive. The text review level, it is qualitative studies, descriptive study, or mixed method for exploratory design. The lowest level is expert opinion and report. Sometimes expert opinion, this is come from experience, but our own experience, we have to give an evidence. We have to try, we have to test it, and they get a result so they can be generalized later on. Okay, what is the goal of evidence? So, okay, so evidence-based is good, and we have level. Why we are use evidence-based? The first one, it is safe, effective, and high quality nursing care. This is the issue. That is the meaning. Evidence-based practice ensure what is Meshack and Kaye and all this is operating nurse they are doing to save effective. What also to minimize the risk. Why this is the percentage of this infected solution? I put it 1%, 2%, 3%. Based on what? So this is very important to avoid and minimize this. As well as we have enhanced the patient outcome. It is very important. Also, operating room efficiency. So now we are deal here not only with the patient, we are deal with the patient, with the instrument, with the environment, with the solution that we are using, as well as continuing professional development. Continuing professional development not only for the nurses, but also for all the staff, even the staff assistant, the cleaner, and the first aid. For this, the people they are working in operating theater, they are also important to attend for their professional development. The benefit is also reduced surgical site infection and the complication. This is what infection control. For this reason, we said success sterilization. This success, when we say success and we have competent or we have mastered, that is 100%. We are not accepted. 99.9%, we are not accepted. All of this operating the theater, it has to be mastered. Competent, 99.9, not accepted, 100%. Enhance patient safety, as we said, improve the efficiency and ensure the compliance for the standard. This is very crucial. Why we are, when Kaye said, guilty or unguilty, guilty or unguilty, because this is the compliance for the standard. Because if you are guilty, that is the meaning you didn't keep the standard. That is the meaning you didn't compliance for aseptic technique. You didn't compliance for hand hygiene. You didn't compliance for the number of the cotton or the goods that you are using in this one. So evidence-based practice is the first step in all practice that you have it. Important, improve patient safety, enhance the quality of care, remote sterilization, standardization, and this is very important, standard, especially with WHO guideline, facilitate informed decision-making, reduce health costs, encourage interdisciplinary collaboration, and meet regularity and accreditation standard. No hospital without any education development center or in-service training are accepted for accreditation, except they have this is the in-service training for the evidence and the apply evidence-based practice. What is the key point here in the evidence-based? Clinical skills. We are all evidence is evidence-based is for clinical skill. Why we are follow this is the 8 steps for hand hygiene. Why? Because this is the correct. And also critical thinking. Why you use it this one before this one? Why we are? What is the important? What is the difference? If I wear my gown before I enter the operating room, and we are, this is guilty, as Kaye said, this is guilty. Because the environment outside maybe have some microorganisms. That is the meaning you are do something wrong, and also they are make an error and the process, and they are also introduce some risk factors for the patient himself. It is also patient-centered because all our operating, all of us, the instrument, the material, the doctor, the physician, everyone, all of us who are working together for the patient himself. Also, continuous learning and the global health standard, it is very important here to provide safe, effective highlight, to bridge the gap between research and the bedside practice. This is exactly what the two speakers, they speak about. What is the practice in the operating theater? What is the importance of attire? What is the importance of the glove, short glove of long glove? What is the importance of the arrangement of the, what is the importance to go this is much before or after? What is the important? Because really, this is all of this is one to save the patient life, to improve patient outcome, reduce error, promote effectiveness. How we can implement evidence-based practice in pre-operative? Use evidence protocol. This is very crucial. Use evidence protocol for patient assessment and the preparation, infection control, allergy, for example, allergic check. It is apply guideline for pre-operative potting and the medication management. This is for pre-operative. It is some example. It is not all this one. I'm just to give you an example because the time it will not allow us to speak more about this one. In intraoperative, what is the evidence-based practice? Follow the strict aseptic technique based on evidence to prevent a surgical site infection. Use evidence-based positioning technique. Why you put it in lateral? What you put it in the lysotomy? Why? Because all of this one, why we are extend the hand and the support the hand, don't leave the hand down. All of this is one and evidence-based, based on the research result, that it will be based on the centered care of the patient. And also ensure proper surgical count protocol, avoid returned surgical item, and also use update anesthesia monitoring and the practice. And I know that all this is anesthesia monitoring practice are very important. We are heard a lot about when this is young people just coming for minor surgical, and because of mistake of anesthesia, they are lost their life. This is really crucial for this one. What about post-operative? Implement evidence-based pain management, mobilization strategy, monitoring and prevent post-operative complication, mainly deep venous thrombosis, and especially we found that some women, she's put her baby, she got it for this, she used it epidural anesthesia, and they are, please, I have headache, I'm not able to move. And suddenly they get deep venous thrombosis, and when they started to run, she lost her life. All of this one based on what? Based on evidence, based with the result. So it is very important. We have aspect of application here in aseptic technique, strict use of sterilization and the hygiene, as Meshack has said. Patient assessment, use evidence-based checklist for pre-operative evaluation, allergy or something like that. Also, as Meshack said, surgical safety checklist, implementing WHO surgical safety checklist to enhance communication and reduce error, positioning the patient, applying evidence-based positioning to prevent pressure, injury, nerve damage during brain surgery, monitoring and documentation. Use evidence-supported parameter and the tool for vital signs, anesthesia effect, and the intraoperative status. Pain management, employing a multimodal anesthesia protocol to control post-operative pain effectively. Also in infection control, applying guidelines for antibiotic prophylaxis, timing, skin antiseptic, and sterile this is salt, equipment, instrument safety, patient education, communication, and the continuous education. All of this is one we have to apply evidence-based just to nurse, to provide the nurse with updated skill through evidence-based practice. And you see, in conclusion, think like evidence-based, safe, smart, patient focus, and the professional care. Evidence-based practice in nursing ensure nursing care is significantly sound, effective, and tailored to patient needs, making the nurse empowered, confident, and professional, smart. And thank you so much for, I hope that you are got enjoyed and got some information from my own lecture. Thank you, and I'm open for any question. Thank you so much.
Thank you, Professor. That's a lot that you have given unto us in that short time. Like, that's quite a lot that you have been able to give to us. A lot of insight to what is actually obtainable in the operating theater, what we need to do. Thank you so much for that, Professor Hayat. Like, really, really, there are a lot of things, evidence-based practice, and as nurses are majority of people that are present on this call are nurses. You'll agree with me, like from what Prof has said, that evidence-based practice is something that is very important. It's something that we need to be involved in. She mentioned one point that I think that is a very key attribute that a nurse should possess, especially a nurse working in the operating theater. That is critical thinking. Like critical thinking, you need to know, okay, what exactly is happening here? Why is this happening? You need to ask questions, not that we just follow. We need to move beyond just, okay, this is the protocol that they said we should follow and we are just following dogmatically. We need to be able to ask questions. Why is this happening? Why exactly is this going on? How can I improve? Why do I need to do this before this? Why do I need to wash before scrub? You know, all those steps. We need to question all those steps and look for scientific backing for each of these steps. Like, what are the things that are backing them up? And I'm sure you're going to agree with me that when we have a good understanding of this, we're able to do our practice, like put our practice with confidence. Like when we are questioned, we are able to answer those questions boldly. We are able to carry out our actions, our care with confidence because we know the reason. We know why we are doing what we are doing. And that's also a call for us to also be involved in research as nurses. We need to, look out for things that are happening around you and research. You need to search out for what is happening and why it is happening. So those are what we give us evidence. Evidence, like that is what we promote, evidence-based practice. Thank you so much, Professor Ayat. Thank you for reminding us some of these things that we need to put in place. And I'm sure you are still going to be available to take up some of our questions. So we are now at the session of question and answer. We are at the session of question and answer. I'm sure some of us have questions that we have from the first session, the first, the second, and the third session. So any question that you have, you can drop now, and our presenters will be here to take your questions and answer the questions, or even if it is just contributions. Okay, so before I'm going to quickly look at the comment section. I have one of the questions though answered, but I'm still going to read it out for the sake of those that are listening. So I have one of the questions. One of the questions says, how do we manage those doctors who are not wearing their masks properly when the sterile feed is already established? I think that question is meant for Meshack John. You took the topic sterile feed, the sterile technique. So that this question is how, okay, or either of you, okay, Kaye or Meshack can answer that question. How do we manage doctors who are not wearing their masks properly when the sterile feed is already established?
Yeah, I can respond to that question. Actually, there is two ways of scrubbing, using soap and water, also using only alcohol-based antiseptic without using water. So others, they can do scrubbing with the soap and the water, and then they end up cleansing with the alcohol-based antiseptic. So
No,
if they are,
sorry. Excuse me,
so
John.
for specific, yes.
Yeah, the question is about face masks. The question is on the face masks. The issue of doctors not wearing their masks properly.
Okay. Of course. Let me say, the issue is attire.
Yeah,
I think that is
attire. Okay, yeah.
attire. Of course, that is a challenge because a face mask should have to cover the nose and the mouth, even to cover the chin, so that at least it can, because breathing with that mask covering the nose can lead to contamination. So that can be strictly prohibited. And keeping in mind, the nurse, a scrub nurse, and a operating nurse are the leader of the operating room. So if you are very strict, even a surgeon who came inside the operating room will know maybe Mr. Meshack is very strict, so they have to adhere to the standard. But generally, that should be, you have to make a standard in the operating room that this rule should be adhered to every person in the operating room. So mind you that mostly surgeons are negligence. Surgeons and anesthetists are negligence of aseptic adherence. So a nurse is the one who is leading the aseptic technique in the operating room. So I think he has to take that point.
Oh.
Yes.
Thank you so much. Thank you. Kaye, do you have anything to say?
Yes, thank you, Titi. With regards to wearing of masks, is that about wearing masks?
Yeah.
What do we do for those who doesn't comply?
Yeah.
As I think I mentioned in one of the question and answer portion in our Zoom, that it's important that we remind our doctors or whoever member of the operating room team to be compliant. I respectfully remind them about wearing proper mask. And some hospitals practices posting of signages so that you don't really have to call attention of people. It's just there posted that you are supposed to wear a certain perioperative attire inside a certain area. So that's a tangible and discrete reminder for everyone to wear their proper operating room attire, including the masks.
Yeah. Thank you so much. That is very important. I think that question has been answered. This question also goes to John again. I think that was one that you were trying to take before, that says, what would be your stand for those perioperative personnel, nurses and doctors who are not scrubbing their hands anymore? Yeah, instead they are just rubbing their hands with alcohol. That is the gel, using the alcohol gel, then do ganning and gloving right away. They just use the alcohol rub, and then they put on their gown and gloving right away. She said it really saddens me to see this kind of practices now. Would it be possible to issue a universal policy and regulation with this kind of practices for patient safety? What do you have to say about that, please?
Yeah, thank you, Titi. Again, in responding to this that question, he said that rubbing using alcohol. Actually, alcohol is allowed to use during scrubbing, but only if a nurse or surgeon follow the standard guideline, standard operating procedure for alcohol-based antiseptic for scrubbing. In some countries, for instance, I was in one hospital in Germany. They don't use soap and water at all. They only use alcohol-based antiseptic. This is sterilization. So, but that can be done by scrubbing. You use the alcohol antiseptic for 90 seconds. Follow all the procedure like you are scrubbing using water. So for 90 seconds, it's okay. But if he's just rubbing just for half a minute or 10 seconds, that is not allowed. But if he can follow for 90 seconds, it's okay. And follow all those stages for scrubbing. It is allowed and it can be okay.
Yeah.
Thank you.
Yeah.
Yes.
Yeah, thank you so much, John. I think all the steps, it should be emphasized that all the steps should be followed. And I think one of the things that can help is part of what Kaye said, like there should be posters, like maybe posters should be placed, and where people can see it very well, where people can see it and view that, okay, these are the steps that is obtainable to hand washing, to preparing yourself when you are entering into the OR. We should not just assume that everybody knows it. We should keep reminding everybody in the team. Thank you so much. Okay, I'm trying to see if there are more questions that are coming in. There are more questions coming in. It says, what are some of the chemicals or disinfectants should one use while cleaning the catheters used in cath lab OT? I don't know. Are we able to answer that question? Chemicals or disinfectants that should be used while cleaning catheters used in the cath lab?
For catheter. So I'm not sure of those catheter actually, because I'm not working in a cardiovascular surgery. Maybe we can hear opinion from other participants.
Yeah. Yeah, Titi, I just would like to come in if it's okay. Vinitha here.
Yes, ma'am. Yes, ma'am.
Yes. That's a very good question. I really outright say I don't know, because I've never worked inside cath lab or even an OR. I've been a post-operative nurse most of the time. But the most common thing that I have seen being used for catheters, or rubber material which cannot be autoclaved, a chemical disinfectant that we very commonly use in our hospital is the glutaraldehyde or the Sidex solution that we use. And I'm not sure that that can be used in cath lab, but in an OR for our instruments and for our some of our goods, that is what we use very commonly, because Sidex is among all the chemical disinfectant. Sidex is the one which is really very active or good against most of the organisms including virus and microbes. So we use that. I'm sure we all use it extensively. But I cannot say for cath lab specifically. If somebody else here works in cath lab or any of the labs, and if they use anything else, can you please share the answer? That'd be very good.
Prof. Vinitha, Titi.
Okay.
I think what Prof. Vinitha has mentioned about using glutaraldehyde is quite acceptable with regards to the type of disinfectant that we use inside the operating room or in the cath lab. But there are other options, like for example, we can also have bleach solutions. There's just a general guideline with regards to the mixing of the bleach solution, like for example 5 tablespoons into a gallon of water, or whichever is applicable in their standards of infection control. And there could also be alcohol-based solutions, aside from, of course, the commercial disinfectants like the glutaraldehyde or some hydrogen peroxide mixtures.
Okay. Yeah. Thank you. I think there is a response to that question. Someone said that this is a response to that question, that you could reach out to the representative of the company, to see what sterilization procedure, like they could be able to direct you to say, okay, these are exactly what could be done, or chemicals that can be used without breaking down the catheter, because that is also very important. You want to maintain the quality, like the potency of the catheter itself. You don't want it to damage. You don't want that catheter, the catheter to be damaged. So I think it's also safe if you are going to be reaching out to the representative or the company to check which of the which sterilization procedure is safe for that equipment. Thank you so much for all your
And Titi,
responses. Yeah.
if I may add, there's an instruction for use from every manufacturer for
Yeah.
any supply that they can use as reference for the standard or recommended disinfectant that they could use for every item.
Yeah, absolutely. That's correct. So another question, I think that was going to be the last question, just to save time. I know some say have some other questions, but I think let's take this as the last question because we are trying to save time now. So what happens when a major instrument falls down during a surgery? If a major instrument falls down during a surgery, and back to the mind of the surgical team, that is a crucial instrument a surgeon is expected to use concurrently in the surgery. So what happens when a major instrument falls down during the surgery? That's the person's question.
Yeah. Hello.
This is very important questions, really. The current, excuse me, just that I wanted to say something about this question. Before, for example, before this is the disposable instrument, and with this individual instrument separate like this one, before everything we put it in autoclave and everything we put it in sterilization, and we thought not easy. For example, 20 years ago, when we are working on operating theater, everything it will be not as well. And really what happened is happened for me. And as I mentioned you, for evidence-based, they have to be working in pressure situation. All of it, and this communication, the evidence-based, they said at any time when you have any surgical, any accident like this one, it is a mess, really. All of the stuff here, it has to be controlled themselves. The first issue have to concern about what? Concern about the safety of the patient, to ensure that no vein is will cutting and no everything, ensure that all the area is clean, all the area it is safe. And also, as we have scrub nurses, the circulating nurse, we are looking that circulating nurse should be apply all this instrument directly, so it will not take minutes. This is my experience during when I working on operating theater, and this has happened for us, and it will be better for them. So the first issue is control your emotion. Don't cry, don't shout, don't do anything. And the scrub nurse, they have looking for the circulating nurse. The circulating nurse should be important and fastly use it, because they mentioned any minute it will make a difference in the patient life. Immediately to are preparing the needed instrument directly till they will control the continue. This my contribution, but I think Meshack and Kaye, they can do something also because they are in the field. This is long year ago when I have some experience like this one, and when the evidence base, they said control your emotion, prepare yourself directly, ensure the patient that they are safely, and they ensure the patient they are not make any error. The scrub nurses, they have to prepare the equipment fastly. Thank you.
Thank you, Prof.
Yeah, I'll be
Yes.
muted. Thank you, Prof, for that contribution. Okay, Professor, you want to add to that? Prof Vinitha, do you want to add to Prof's contribution, ma'am?
No, I did not. I was just about to ask Kay or John whether they have this real incident maybe recently happened and what they did.
Yeah. Of course, what we do in our operating room, if maybe an instrument is dropped down and we need to use it, a circulating nurse will take that instrument and decontaminate it, following the procedure of sort of cleaning. Then after we put it in a chemical sterilizer, which is a Silex. Then we put, after maybe like 15 minutes, we take it and rinse with normal saline. Then we use it. So that is the common way we use, because instruments to drop mostly happen. Some very critical instruments, they drop down and then we still need them. So we do it that way. We decontaminate, then we put in Silex, then after 15 minutes, we take back to sterile filter. And sometimes we can open another kit, instrument kit.
Another one, if I may add, some facilities also have fast sterilizer in cases of instruments that's unexpectedly fell. So if you do not have any replacement, so there's a fast sterilizer that they use so that it's going to be easy to re-sterilize or reprocess the instrument again.
Okay. Yeah. Thank you so much. Thank you. So this one is for Professor Ayat. I just wanted to touch quickly on it. Where can we access the evidence-based practice research? It will be a good tool for us all. Like, where can we access the evidence-based practice research?
Yes, I'm just answer this question. Cochrane, PubMed, Sunhill, all this is one. It is the reliable websites. Reliable websites for this Cochrane with evidence, with evidence-based nursing. And I mentioned, I'm just answer this one. Maybe I will raise this issue for to the host and this the chairman of this GICS to. Maybe we can hold one meeting or one webinar about evidence-based only. How we can use evidence-based, because evidence-based we have to use a lot. We have, when I mentioned this is a level based on BICO, patient, the intervention, the condition, the outcome, and the time now. And all of this one, what is the question you wanted to answer? What is the operational definition that you wanted? And what is the term that you wanted to use it? All of this one, when I mentioned in my own evidence-based practice, is tailored to the patient himself. It is not all the patient like that. Not any cesarean section is the same. Not any appendectomy is the same. Not anything. The patient, if it's the patient himself, if he going some operation this year and after 5 years, it is not the same. So what we have to do, we have to apply BICO. What is the characteristic of the patient and also the condition here? Maybe in developed country, maybe in the developing country is different. It's different if the patient is male or female, if it's the highly economic or low economic. All of this one, we have evidence-based to ensure that we are provide the care for the patient effectively and tailor the team care and ensure the quality of nursing care and the best outcome for the patient. Thank you. Yes, Prof. Vinitha, you want to say something?
Yes, I just would like to add to what you said, Prof. It's very important that we access evidence. That question is very pertinent, that we need to really add or look at evidence in the platforms that Professor Hyatt mentioned, where we have evidences available in Cochrane Library and JBI systematic review findings. All these are very good evidence. And one of the example, and I was thinking we must look for evidence, is what one of the speakers, Meshack, just mentioned. And we were discussing about whether hand scrubbing is okay, scrubbing with soap and water, or just washing with a rub. Is that okay? An alcohol rub, 90 seconds. Is that okay? Is it from evidence? I'm sure it's from evidence. And if it is so, where is the evidence? And we can look at it, and that'll be a nice way of looking at what is the level of evidence for that rub, whether it is okay, it's better than hand wash. Those are some things that we can look at when we are thinking of evidence-based practice. And so we can really truly say this is the best practice because the level of evidence is very high.
Yes,
So,
yes, of
yeah,
course,
that's
Dr. Vinitha, thank you so much. I would like to say something also. You know, maybe Kaye and the Meshack, they know that we try now, if it we are working before 10 years or 15 years ago, you will find that we are avoid some unneeded procedure. For example, we are avoid shaving the area before, in the operating incision. We are also avoid this enema before. We are avoid many of unneeded procedure. We are avoid some, this is the prophylactic antibiotic after surgery. We are avoid all this one to reduce the cost of the patient and to reduce the burden of the patient and to ensure this is the what we call it the natural immune system of the patient. So all of this one come from evidence based. Why we are, as I said for you, why we are, this is the concentration of antiseptic solution, it is so. Why we are use alcohol and not use betadine? Why we are use open surgery, open wound? We have to use this one and avoid this one. You understand? So all of this one come from evidence. And please, I'm really encouraged. All this is the hospital chief medical director, and this is the principal of the nursing, or principal of schools, and also this is the nursing officer. Please try to introduce your staff for evidence-based. Open their mind if there are something to apply. It is not routine care. Routine care, if it's yourself, routine care for yourself, it will be like redundancy and you will feel boring and you will not add. Critical thinking, good communication, all the time ask a question, why I use this one, I not use this one, and all the time try to find, all the time try to read. And if somebody mentioned any word and you didn't know this word or this definition, go and Google it and did know. All of the time try to add yourself. I'm encourage you here at the staff, academic staff. Academic staff, we are enrich you to good information, and this information, it will give you the wisdom for decision making. Thank you so much.
Yeah. Thank you so much, Prof. Thank you for all the contributions that you have made. That is just to open our mind to the fact that it is important for us to continuous professional development is very, very important. Continuous professional, we should keep updating ourselves, keep reading, keep getting into research. Even as nurses, we should not just plateau or think, yes, based on what we have, we know it all. We should keep researching, we should keep updating our knowledge. So that is very important. Thank you so much for all the contributions. Thank you to all our speakers and for all the questions that you have asked. I hope you've gotten all answers to all of your questions. So now we've come to the end of the presentation, and I'm going to be handing over back to the chairman of the Nursing Working Group of GICS for updates on GICS. She was going to giving us updates on GICS and the closing remark. You're welcome, ma'am, Professor Vinitha.
Before would you like to share the this one, Kaye? Register or people can do? Okay. I just would like to thank, and I'm not going to really. Would you like to share the? I mean, sorry, Kaye. I'm.
Can you see that now?
Yes, this comes as question answer. Yes, sorry, thanks. That'll be really good. I just would like to tell the group that we are having a GICS meeting in Bogota, Colombia, in April between 24th and 26th, 2026. So you're all invited. Make sure you become a part of this meeting. And as nurses, we can participate as nurses working group. And we have the privilege of sending abstracts, or if our abstracts are accepted, we'll be able to participate. You can participate as members as well. We are planning to have a workshop which concentrates or focus on nursing care of surgically ill children. We haven't decided on the topic, but we'll very shortly decide on the workshop, as well as a collaborative research that we can do and present. So if you are wanting to be part of it, we request you to join us, become members. You are requested to go to the GICS website, and you can become members of the Nursing Working Group. The registration or the payment for the membership is $10 per year. You can be a paid member, or you can also be a member who, if you're not willing to pay, you can be a non-paid member as well. So I, at this time, take this opportunity to invite each one of you, if you're not part of GICS Nursing Working Group, and if you're a nurse and would like to join, you're welcome to join us. And we have regular meetings. We think of, we plan for these webinars and other activities. And we try to, the focus is to improve care for our surgically ill children and make the outcomes better. Thank you. Over to you, Titi.
Okay. Thank you so much, everyone. Once again, thank you, Prof, for that update. If you are not part of us, we encourage that you join the GICS Nursing Working Group. We believe that we can learn from one another. We can get updates from different areas, different experiences that we have. We have nurses working in different aspects, different regions of the world. So we'd like you to be part of us, to join us so that we can learn from one another. Thank you so much as you join. So now the QR code that is on the screen right now is for us to scan so that we can mark attendance. We want to know all those that have participated, everyone that have joined us. We would like to know you. We like to have your details. So we encourage everyone to kindly scan the QR code so that we can have your name as part of the attendance. Thank you so much. We'll leave it for a couple of minutes a couple of seconds before we take the closing remark. I'll be handing over back to the chair of the nursing group, Professor Vinitha. So please let us scan the QR code just to mark our attendance. So while Prof is taking the closing remark, I think we can still leave that on. We can still leave that on, Kaye, please, while I hand over to Prof Vinitha to take the closing remark.
Okay, thank you. I just have just no words to say thank you to the panelists today. Thank you for the efforts that you have put in sharing your knowledge and your points related to different aspects of infection control in OR, making sure that our outcomes, especially for our surgically ill children, are much better. And this is an important aspect that we discussed today. We could not discuss cover all the points, but I'm sure we covered the most important things that we have to remember. And especially at this time, I would like to thank Kathleen here, who led this session today, the webinar. She was the one who planned and made sure this webinar was executed perfectly. And at this time, I really would like to thank her specifically for all her efforts and all that she did towards making this a success. And of course, the other panelists, John Meshack and Professor Hyatt, thank you very much for your participation. And Titi, our secretary for our nursing working group, for taking us through and being the moderator of this session and doing that beautifully. And last but not the least, all the participants who today participated actively with your questions, thought-provoking questions, and also sharing important insights. It is not that we are experts, that we are here, but it's just sharing knowledge. Each one of us are from different backgrounds, different countries, and our practices may be different. We always welcome your thoughts, and you might have better practices which you can share with us. So at any time, at any webinar, at any meetings, we invite you to share your best practices with us so that we can learn together and make things better for our children. So thank you for spending a lot of time this evening, more than 1 hour, although we wanted to finish, but it was a very insightful and useful session. Thank you, each one of you.
Thank you so much.
Thank you so much. Yeah, so thank you. Kay, some people are having issues with scanning the QR code. I think we look into that and possibly drop it on our page, on the WhatsApp page. Is that okay? The QR code.
Yeah,
Some
Yes.
people are
that will
having
do.
issues with it. Yeah. So I think we can look into that and drop it on our page so we don't keep everyone too long. Thank you so much once again for joining, and I think it's a good time to say bye-bye.
Yeah, bye-bye, Titi, and all of you.
Everyone.
Bye-bye.
Your registration information are available, will be available to us. So anyway, we'll know. We just wanted to know for sure who are the ones who participated. So hopefully we'll get some.
Thank you so much. You will not take a photo. You will not take photo. I remember that you wanted to take photo.
Yeah, we wanted to take the photo, but there
No,
was
you
no way
mentioned
to.
that. You see, mentioned that. Stop sharing, and everyone, he have participant. He can open his camera and they can take photo with us. No problem.
Okay, so anyone that wants to take a group photo, we
Yeah.
would love to take a group photo. So you can put on your camera. Okay, are you able to do that? I don't know. I know you said you were not.
I can take a photo, but I'm not sure if the participants can be able to join. Are they able to join?
Okay.
So let's try.
Stop sharing and they try. I think allow them that they are open their camera. If you have the setting, allow participants to open their video, so it will be good. Okay.
Yeah, so let's try.
Yeah. Yeah.
Smile. Okay.
You know, sometimes the participants they like to share with us.
Yeah. But
okay.
I don't know if I'm able to get that.
Okay, don't worry. I will take one. I will take one for you. Okay. Yeah, I will take another one. Okay. I will take another one. I will forward it to you in the platform.
Okay.
Thank
you,
you,
Professor. Thank you, ma'am. It's Nice
You are
sharing
welcome.
this space with
Nice
you.
to meet all
Thank
of you.
Yes,
Yeah.
ma'am.
Thank you so much. Okay.
Thank
Now
you.
many people are
Goodbye.
here.
Bye.
Bye bye. Bye bye.
Goodbye.
Bye bye.
We'll see how we can get the certificate, Nelson. We haven't done that so far, but hope we'll be able to do it in the future. Thank you for your question. Thank you. Bye-bye, Kaye and everyone. Thank you. Meshack, Kaye.
Yeah, bye-bye.
Off. See you in our next meeting.
Yes.
Thank
Yeah.
you.
Bye.
Good. Okay. Bye.